Assalamu alaikum everyone. Am I Hello, Assalamu alaikum.
वालेकुम सलाम जी कंटिन्यू करें प्लीज
Okay, so Assalamu alaikum everyone. I am Kasmala Azam, a fourth year medical student at Rawalpindi Medical University. Currently, I am working as Senior Vice President, OHEC. Organization of Health and Economic Collaboration is a non-government student-based organization founded on 23rd March 2021 with the slogan of Building Lives with Every Step by Danish Ali. Currently, we are doing a health awareness campaign, and today is the last session of our health awareness series. We have our worthy speaker and mentor, Dr. Sohail Aman, with us from USA in this session. Health being our topmost priority, currently OHEC is working on many other health projects as well. We are working on setting up a digital health system nationwide that will be elaborated later on soon, and this will be inaugurated soon as well. With that being said, without wasting further time, I like Dr. Sohail Aman to take over the charge of the session, and he'll be speaking over cardiac chest pains and will be answering our queries. Over to you, sir.
so you mute, kindly open your mic.
Assalamu alaikum.
Assalamu
Assalamu
alaikum.
alaikum. Can you guys hear me now?
Yes sir, sure.
Walaikum assalam. Okay, how many people are here in the Zoom meeting?
Specifically in the meet we have 22, like these are our own members and more will be joining, and there are many more, but they will be on live on the Facebook page.
So you all from Rawalpindi Medical, or they are from different medical colleges?
So we have combined audience, like from different medical colleges. Also we have other people or students, you can say, from non-medical fields.
Okay. So basically, I've been told that this forum would be for the USMLE
Right, sir.
preparation and regarding question and answer session and for the health awareness. How many people are from fourth year and final year, and how many from preclinical side? Can we do we have their
Sir, actually, it was basically for health awareness, and regarding USMLE, what I said was that there were few questions in the registration link about USMLE, so we can just look for them at the end.
Okay, because if there are more fourth year and final year students, then I will be talking about chest pain on clinical basis. If there are more students from first year, of course, they won't understand about the clinical side. So that's why I'm asking.
So we have more of the audience
So
from
there are many
third years and onwards.
Okay, so they have the basic
Yeah.
sciences. They understand about. They have the basic knowledge of anatomy and physiology, how cardiovascular system works. So we can basically talk about the
Yes.
disease then.
Right.
Yes, sir.
Okay. So let's talk briefly about the chest pain. Everyone, chest pain actually is basically what we call is angina. Angina is when you have your blood supply to the heart is compromised. And what it means is that there is always a demand and supply ratio. How much your heart is asking for oxygen and how much you are providing oxygen to the heart. So this is demand and supply. When this ratio is disturbed, like when you are exercising or when you are running, you need more oxygen. So when you ask for more oxygen, then your heart should provide more oxygen to the body. But if there is imbalance between demand and supply, you are demanding more oxygen and you are supplying less oxygen, then what happens is that you get into chest pain, which is angina. Angina is lack of blood supply to the heart. This is I'm talking about at very basic level, but it's more complicated. Um, so when we talk about angina, there are two types of angina. Now you know the angina is a chest pain I'm talking about, right? So it has two components. One is the stable component and one is the unstable component. These are two types of angina we call stable angina and unstable angina. They are both are different. So when we talk about stable angina, what are the main features of stable angina and how you recognize stable angina from unstable angina? This is very important. So the way we differentiate between stable angina and unstable angina is based on history and physical. Number two are the labs, and number three is your ECG. These are the main three things that we look once patient presents to us with the complaint of chest pain. Then you have to decide whether this chest pain is coming from the heart or this is kind of maybe muscle pain and this is not a heart pain. So this is very important that you guys have to differentiate. Now, how are you going to differentiate between a heart pain, which is stable angina, and non-cardiac pain, which could be muscle pain? First, you have to ask from the history the risk factors. Now, when you talk about the risk factors, there are 5 risk factors for the heart or chest pain or angina. Now, what are those risk factors? Number 1 is high blood pressure, hypertension. Number 2, diabetes. Number 3, smoking. Number 4, family history. And number 5, obesity. And number 6, high cholesterol. So these are risk factors. If patient has all of them and it comes, doctor, I have a chest pain, do not send those patients home. Because if patient has all the risk factors and they are coming, then you have, even if their physical exam you could not find, still you cannot send those patients home. So then what you do, you have to get the ECG, okay? And if patient has a chest pain, give some nitroglycerin, which is you give under the tongue. It's a vasodilator. It dilates your arteries of the heart and it relieves your chest pain. So first thing is you have to ask about the risk factors uh, for the chest pain. Now, once you have done it, and then go order the ECG. The ECG will show you there are specific changes on the ECG that will tell you if patient is having a chest pain, and there are T wave inversions. I don't know how much you know about the ECG now, but once you learn about ECG, then you will see the T wave inversions on the ECG lead that would tell you that patient is having a chest pain coming from the heart. Okay, so these are some of the basic things that you cannot ignore. Number one is the history, physical. You ask about the risk factors, and then what were the circumstances. Say if patient is smoking 30, 40 years, okay, he is diabetic, he has high cholesterol, he has high blood pressure, then the chances are that this chest pain is coming from the angina. Okay, so you do the ECG now. ECG, you see the T wave inversions. Then this will confirm that patient is angina. You have to admit the patient, and then we'll proceed with further testing, like we do the stress test. The second one is unstable angina. Unstable angina is an emergency, means patient is having like a heart attack. What we call heart attack is unstable angina, and what happens is that there is a blockage. The stable angina is there is a problem with the demand and supply of the oxygen. Like if you're exercising, you need more oxygen, but when you rest, your chest pain will go away. So this is stable angina. Chest pain on exertion, chest pain relieved on rest. So this is stable angina. Unstable angina is chest pain on rest. Patient is watching TV, having some tea or coffee, or having some reading newspaper, and all of a sudden he has chest pain on rest. This is more dangerous than means he's having heart attack, and he needs to go to the emergency department immediately. And what you see on the ECG is ST elevation. The ST elevation on ECG is the what we call heart attack or STEMI, or ST elevation MI. That patient is having MI. And if you check the cardiac enzymes, they will be elevated. So those patients should go to the cardiac cath, or they should go for the angiogram, and then they go and the cardiologist, they will put a stent in and relieve the blockage. If you do not have a facility where you can do the heart cath, like you are sitting somewhere in the remote area, then what you do is you give the TPA. TPA is like it will dissolve the clot, the blood clot inside the heart. So this we give the medicine if patient cannot reach to the cath lab. If you are like right in the Rawalpindi or somewhere where you have the access, then patient should go within 1 hour, and they take it to the heart cath, and then they relieve the blockage and put the stent in. So this is for the unstable angina, or for the what we call ST elevation MI. So that is how you differentiate between the stable angina and unstable angina. There are two types. Now, from the once you admit patient and you have say you have diagnosed patient with stable angina, then always check the cholesterol, always check patient sugars, always check blood pressure, and then you will send that patient for the stress test. Stress test is you make patient run on a treadmill for 12 to 16 minutes, and then you see, you basically what you're doing is checking the demand and supply. You, because on exercise, this chest pain comes on exercise. So you try to see how much your heart can take the exercise, and if patient started having a chest pain, means then there is some blockage, then you have to send this patient, then they have the stress test is positive. If you have a positive stress test, then this patient needs to go to the heart cath, and they will do the cardiac cath and see if there's any blockages in the arteries, and then they will put stent in and they leave the. So this is stable angina treatment. And then we have already talked about unstable when you have a ST elevation. So once you have fixed the blockages, then send patient home on aspirin. Aspirin is the blood thinner. Okay, send patient on blood thinner, aspirin. If you have put a stent in, then you need an extra blood thinner. So send patient on 2 blood thinners for 1 year, and after 1 year they can continue with aspirin, because with stent you have to have double coverage. So give patient 2 blood thinners or aspirin and Plavix if patient has a stent in. The second thing is control the blood pressure. So for blood pressure, there are 3 or 4 medicines. Make sure you can give beta blockers, you can give calcium channel blockers, you can give hydrochlorothiazide or diuretics, or you can give the ACE inhibitors. There are 4 different categories of blood pressure medications. So make sure their blood pressure is controlled, then start on a cholesterol medicine to decrease their cholesterol. And if they are diabetic, then of course you have to either give the diabetic medicines or start them on insulin. So that is how you control their risk factors too. And then if patient is obese, tell them to lose weight, and then they have to walk every day, eat healthy, low cholesterol, low fatty food, no fried food. And if they are smoking, ask them to stop smoking. So that is how you follow up those patients. So this is in a very brief, I have mentioned about the chest pain, the stable angina and unstable angina, and heart attacks. That's how we treat patient. Now I will take any questions. So we'll go from your level, what you guys need to understand, and what you guys, what kind of difficulty you have in understanding chest pains. So let me know then. Kishmala, can you take questions?
Yeah, sure, sir. I'll be asking questions one by one. Okay, so we have a question that how to differentiate between different chest pains. Like every chest pain seems to be like of cardiac pain.
Well, like I mentioned, risk factors. Always try to address risk. If they have risk factors, then this is more likely cardiac chest pain. If patient is like 20 years old, 25, and they do not have diabetes, they do not have high blood pressure, they do not have cholesterol, and they come with a chest pain, then more likely this is a muscle pain. Okay. Now, if the same patient is 60 years old and they've been smoking for 40 years, high blood pressure, diabetes, high cholesterol, they come with all the risk factors, then this is more likely this is a heart pain. Then you have to admit the patient and start treatment, and then get the ECG and get the enzymes, lab testing, and then do the stress test. So it all based on the risk factors. You have to ask from every patient. That's how you differentiate. Some patients who are obese, They may have acid reflux, which is causing chest pain. Some patients are having pneumonia, they have fever, cough, you get the chest x-rays, pneumonia, so this is not a heart pain. So it's based on your differential diagnosis. So you have to have a very good history taking, ask about the risk factors from every patient, and then you need to have a very good differential diagnosis. Based on that, you differentiate.
Okay, next we have a question that when is chest pain an emergency?
The chest pain is an emergency when you think that this chest pain is coming from on rest, like patient has all the risk factors, and chest pain is on rest, which is unstable angina, then this is kind of emergency. Do not send those patients home. You have to admit it, get the ECG, and if you see ST elevation on the ECG, then this is an emergency. Either you have to send them directly to the heart cath, or give the TPA, which is kind of a clot blood buster, or which dissolves the blood clot inside the heart. So this is an emergency then.
Okay, next we have how important it is for a cardiac patient to follow the medication schedule properly. Like, does skipping medication be dangerous for a patient who had an anginal attack back in a year or so and is currently on long-term medication?
I didn't get the question. Can you repeat it?
Yeah, someone asked that how important it is for a patient who had an anginal attack back and is currently on medication to follow the medication schedule properly. Like, does skipping medication is dangerous?
No, they have to keep taking medications. It's extremely important because you have to reduce the risk factors. Okay, if they are exposed to risk, then you have to take medications. Otherwise, they will have another heart attack, which will be more severe. So it's very important to prevent them having another heart attack, which could be life-threatening. They could die. You have to take medicines. That's the only way to go. Otherwise, you will end up having a bypass surgery that they have to change, or they have to bypass your heart arteries. So it's very important to keep taking your medications. There's no other alternative.
Okay, someone asked, can stress and depression be the reason of cardiac pain?
Yes, very good question. It can be, but this cardiac pain is not angina. It is coming from your mind. So you have to give them antidepressants. That's why the differential diagnosis is very important. If your depression is causing chest pain, then give antidepressants. This will relieve your chest pain. So then you have to ask about depression, why patient is depressed, and diagnose depression properly. And one of the symptoms of depression is chest pain. But this chest pain is coming from depression, not from angina. So give antidepressants. So that's why your differential diagnosis have to be very strong.
Okay, someone asked, what can we give to a patient at home having severe chest pain before going to hospital?
Aspirin, give aspirin 1 dose, and if you have a nitroglycerin, which will hold under the tongue, give that 2 medications, aspirin and nitroglycerin, and then take them to the hospital as soon as possible.
Okay, someone asked, how to manage a patient with MI in an area with no medical facilities?
Yes, so like I said, if you have MI, first you have to give them aspirin, okay? Then give nitroglycerin, okay? And then start on a medicine we call TPA, okay? I don't know what name it comes in Pakistan. So it will dissolve the blood clot inside the heart, okay? It is as good as having a cath. So if you cannot send patient for heart cath, give that medication. Uh, Let me check with which name it comes in Pakistan. TPA.
Altiplace or Altiplace?
Ready, place?
Yes, right.
Okay.
Yes.
So yeah, ready place is the one. So it dissolves the clot. It dissolves the blood clot in the arteries. Okay. So you have to, and it's available from every medical store. Everyone. It's a little expensive, but this is the first treatment. If you cannot send patient for the cath and give this ready place.
Okay, so someone
Okay, so
asked.
there is a scenario-based question, like someone shared personal data, I guess. Someone said that, okay, continue.
Okay, someone asked in the chat that shall we consider angina as the first stage of a myocardial infarction?
Angina is the first stage for myocardial infarction. Yes, the unstable angina, not the stable angina.
So for that angina patient, shall we have to consult a cardiac specialist or a common like general practitioner?
Yes, yes, you have to call cardiology.
Right. So
No,
okay.
cardiology.
Okay, so someone shared a question that he was he's suffering from hypertension. Like the upper limit of systole was 140 a couple of years ago. Then it became 120 and now less than 120. What are the reasons for the foregoing revisions in its value? Like, is it dangerous?
No, it's good. 120/80 is normal blood pressure. It's okay. It's good. If it drops below 90, then it's dangerous.
Okay. What are the reasons for intractable angina?
Again, intractable angina is unstable angina, which is not going away. Usually, angina goes away on rest. It comes on exercise or running and or doing some work, weightlifting, whatever you're doing. But when you rest, it goes away in 5 minutes. But if it's not going, then this is unstable angina. So means patient could have a heart attack very soon. So you have to save the heart. So send that patient quickly, give aspirin, give that blood thinner, that's nitroglycerin under the tongue, and send that patient quickly to the emergency room.
Okay. Someone have on and off severe pain in left arm. Does it emphasize on some underlying cardiac issue? Like it's
Yes,
not continuous.
yes. So when we talk about taking good history, you have to ask about the chest pain. Okay, now chest pain is on rest or chest pain on exertion. Okay, sometimes the chest pain also goes to your left arm, and if patient is having complaining of left arm pain with chest pain, then this is angina.
Okay. Someone asked, have you observed any increase in cardiovascular symptoms after COVID-19? If yes, then how is it presenting now?
It presents in the same way. Yes, we have seen increased cases. Uh, COVID-19 does cause the inflammation actually. It can cause inflammation in the heart and it will cause cardiomyopathy. Second thing, COVID-19 cause blood clots. When it has blood clot, it can also have blood clots inside the heart and cause MI or elevated enzymes. So yes, we have seen increased cases of heart attacks and people have died from that too. So COVID-19, that's why it's very important you take vaccinations, make sure you wear mask and prevent yourself not to take any chances.
Okay, someone asks nitroglycerin and aspirin both can be given in diabetic patients too or not, and same goes for obese persons.
Yes, we can give both.
Okay, how to diagnose or to find the root cause of angina in epileptic patients?
Epileptic patients, whatever the patient is, always, I told you about the 5 or 6 risk factors. Always try to find them first, okay? If they are present, then regardless if patient is epileptic or have any other problems, then there are chances that this is the reason causing the blockage in the heart and having heart attacks. Now, in epileptic patients, if patient is having severe seizures, sometimes what happens is when you have seizures, your oxygen level drop because you are seizing, you are not breathing. And if it's prolonged with no oxygen, yes, it can cause damage to the heart in that sense when you have seizures, but not otherwise.
Okay, next we have a question. How do you see homeopathic treatment for chest pain, and is it the future treatment or not?
I have no idea about homeopathic treatment.
Okay. Someone asked, is there any solution other than medication for a cardiac patient who is on long-term medication? Because taking medicine for long can be irritating at times.
Well, if they don't want to take medications, then ask them to lose weight, no smoking, control their diabetes, okay? Control their blood pressure, do not take any high salt, with healthy exercise and lifestyle changes, and then see if for first 3 months if that makes any difference. If not, then I don't think then they have to
Okay.
take medicines.
Okay. Someone said that, can you please repeat the risk factors you mentioned for unstable angina?
Yes, absolutely. Number one is your high blood pressure. Number two, diabetes. Number three, smoking. Number four, high cholesterol. Number five, your family history, and also obesity. So these are the risk factors you have to ask in every patient who comes with a chest pain.
Okay. Someone said that what can be a good diet that a cardiac patient should prefer?
A low cholesterol diet, like eat more vegetables, more fruits, exercise, low salt, okay, less oily and fried food. So these are the kind of diet they have to take.
Okay, someone said that if someone is 40 plus is age 40 plus and is also a blood pressure patient, so what is the best way to prevent angina or MI? And the patient is taking Loprin daily for blood pressure.
Loprin is not for blood. I think is it Loprin aspirin?
Might be like they just mention Loprin.
Loprin is aspirin. This is not a blood pressure medicine. Well, if you have a blood pressure, then very simple. Just treat your blood pressure. Take your blood pressure medicines. Okay. No matter how old are you, what is your age. If you have a blood pressure, take your blood pressure medicines.
Yes, the Loprin and aspirin are the same.
And uh, so Loprin is not blood pressure medicine. You have to start blood pressure medicine.
Okay. Someone said that as you mentioned, family history as a risk factor for angina. So are cardiac issues heritable like they run in families also?
Yes, they are. Unfortunately, there are some genes which you can inherit from your family, and if your father or mother they have a heart attack in the early age, like if they are 45 and they have heart attack, then means you should check the family history.
Okay. Next we have someone asked that if the person is simultaneously facing the cardiac issue and having the renal problem as well. So does the treatment differs in this case?
No, same treatment. It's just that you have to adjust the dosage for the renal problems. If patient has renal failure, just adjust the dosage, but the treatment remains the same for heart.
What can be the alternative to a myoclone medication if the drug is showing some side effects?
You mean amiodarone?
Amiodarone.
Yeah, amiodarone.
Amiodarone is for atrial fibrillation. Okay, this is not for the heart or chest pain. It is for atrial fibrillation. It does have side effects. It causes on the lungs and cause hypothyroidism. Uh, so if you're taking it for the heart, then this is not the medication to take. It has a lot of toxic side effects. Uh, for the atrial fibrillation, yes, you can take cardizem, which is calcium channel blocker, which is alternative to amiodarone. Then there are antiarrhythmics, uh, uh, which we cannot discuss here. You have to get to the cardiology, get cardiologist consult, and then we have to. They can tell you about that.
Okay, someone asked, is there any difference in treatment related to age, like different age groups be treated with different medications, or it's the same?
Same.
So there is a question that how do you observe like the age, like if I can exactly quote that, what is the minimum age for having cardiac problems based on your observation? Like how do you see different age groups having being affected by this problem, cardiac effects, cardiac pain? Is there any specification?
I have seen minimum age 40, and because the lifestyle has changed so much.
Right.
If someone is smoking, they can have early heart attack. If they start smoking at the age of 10 and they smoke for 30 years, you can see the early heart attack. Otherwise, 60 is the usual age.
Right. So what about the hemophilic
Someone
patients?
asked, what can be the reason of high incidence of MI in young people?
Hmm?
Sir, what about the hemophilic patients? Like, will they be treated like the same way as the normal people? Because there
Yes.
is Loprin popping out again and again that in that case you have to give Loprin, antiplatelet drug.
The Loprin or the aspirin is now the studies say you should not start in primary prevention. It's only for the secondary prevention. Once you have a heart attack already, then you start aspirin or Loprin, not for the primary prevention. It's not recommended anymore.
Right. So, what can be the cause of tachycardia if the ECG or ETT or you can say the blood cholesterol tests are all normal? Is there any other issue related to that?
Of course, tachycardia has many causes. Dehydration is number one. If patient is dehydrated, exercise. Then, if patient has thyrotoxicosis, okay. Then, if patient has any atrial fibrillation or rhythm problem, so there are many other causes which can cause tachycardia. Or if patient is anemic, have low blood count, they all can cause tachycardia. So that's a separate topic. You have to
Right, sir.
have a very good differential diagnosis about tachycardia, what is causing it.
Someone asked that sometimes in babies, like they have some congenital heart issues. So, are congenital heart issues always hereditary, or there's maybe some other cause?
Hereditary, congenital means hereditary by birth.
Okay. What can be the reason of a patient having severe chest pain, but his ECG findings and all other lab tests are normal?
So you have to diagnose whether this is a heart pain or this is a non-cardiac pain. If you have a heart pain, of course, first you have to ask 5 risk factors. Then heart pain is either stable or unstable, stable angina or unstable angina. Now, if you think patient does not have a risk factor and this is not a heart pain, then you start coming towards chest pain from other organs. Like it could be coming from the lungs, okay? In the lungs, the first one is if you have a pulmonary embolism, which means you have a blood clot in the lungs, that could cause chest pain. Then you may have pneumonia, which can also cause chest pain. Then it could be coming from your, if you have stomach ulcer, it could mimic as a chest pain. It could be coming from acid reflux. That could also cause burning pain and chest pain. So then muscle pain, your rib cage pain. If you are a weightlifter, it can cause your musculoskeletal pain. If you are coughing, so then there are so many reasons which can cause non-cardiac chest pain. So for that, you have to have a good differential diagnosis about your other organs, lungs, and your, of course, your GI tract. They all can cause. Then pleurisy can cause inflammation, and inflammation can cause. Then once you rule out about the stable unstable angina, then look for the pericarditis. Pericarditis can cause chest pain. Okay, so you have to have a very good differential diagnosis about these and diseases, and then you need to have a very good predictive value that you can predict whether this is going to be a heart chest pain or not non-cardiac chest pain. So it all depends on your good history taking.
Okay, sir. That's all from the question answer session, and we'll be needing few suggestions from you on some health related projects. Like we are planning to work on a project named OHDC, which is a digital healthcare setup all over Pakistan. So, how do you see this? Like, is it worth so or not? And also, we are
First,
working on a clinical setup. So, can you
is it going to
please?
be a telemetry or telemedicine? What kind of digital setup it is?
Yes, sir, like a sort of telemedicine system.
So in telemedicine, where the doctor would be sitting and where are the patients?
So actually, we are trying our like basic setup to be operated from Rabbini Medical University. Obviously, it has a telemedicine department already working, but we just want to bring that on the level of students. And the idea basically came when we met like Shifa for You and APS, American Physician Society members, and then they told us that they want to start some online projects, sort of like you can say workshop series, etc., etc., on the level of students. So for that purpose, they asked us to join them and then start this chain of telemedicine with them. by the name of OHTC. And first ever project they have like discussed and shared the details also. So it would be about sort of you can say like workshop series. You can tell that. So by
Yes,
that,
first you have to actually you have to first figure out what kind of exam you want to take. You want to take USMLE or you want to take like UK oriented exam, or you have to take Dubai exam or Canadian. The, all these exams are different.
right? So
They ask different things. Okay. So if you are starting on telemedicine, you have to have a group of students who are going for USMLE. Then the other students don't waste their time if they are looking to get lab or wanted to go to MRCP, because they ask different format and different questions.
right,
So first decide which way you want to go. Or you want to do FCPS. FCPS is very close to MRCP and to the UK exams. American exams, they have different requirements. You have to read different books and different questions you have to practice. So first decide about your categories and which students are interested, which way they want to go.
right, sir.
Then start your project.
So it's by the name of Digital Health Certificate course. I have the whole layout. There are 6 modules for that. We'll be starting by that, like first module, second, third, and so on. It will be a certificate course on behalf of OHEC and Rawalpindi Medical University in collaboration with APS. And I'll share the like whole details in the form of document later on. But just to like notify in the meeting and to let you know about that we are going to start, and we need your advices on that also.
You can tell them about, you can guide them what books they need to read if they're going for MRCP, what books they need to read if they are attempting USMLE, like they have to have a U World, they need to do first aid, currents. These are the books that they should read for the USMLE.
Right.
So you can guide on the study material, and then questions are very, very important. And of course, if you can get someone from Aga Khan, they are most current, or from the Shifa, because they are having the same curriculum like Americans have. So that would be more helpful.
Right.
And then I'll try to find someone from here. If we have a medical student from here, we can get your interaction with them.
So we were
This will
discussing
be
about
very
the
helpful
session
for
on
the students.
previous days on USMLE. If we can that get that right now, because many students will be taking USMLE exam in fourth year or start of their final year. So it will be like very good for them and for us obviously also to get the up-to-date knowledge about the study materials.
Right. I'll try to see if someone is available from here. We'll see. And then, of course, yeah, that would be very helpful, right? I agree.
Right, sir. Also, sir, there is another project that I happily want to like share here with all of you. That we have started a small clinical setup, like sort of like one doctor program, so he can sit like 3 or 4 hours in a day or like that, and just share the consultancy and almost you can say free of cost medicine. So that's a part of our program also. So as to spread free
Good.
health, taking your mission forward, inshallah. And
Good, very good.
that's all on my side. Kashmala, you can continue, please.
Okay, so thank you so much, sir, for your time, and thank you for always being here for us and motivating and guiding us. And today was the last session of our health awareness series. Like we conducted a series of sessions on mental health, on diet, and on many other issues as well. So I'll just like to take your closing remarks. How do you see all this awareness campaign, and what will you like to advise us all?
Well, these 5 years are the most important years of your life. Uh, at this time, if you make correct decisions, it will last forever. So try to make sure that whatever decisions you make in your life, that will impact your life in a positive way, and it will go a long way for you. So take it seriously. That's what I say. Take it seriously. You can have fun, whatever you want to, but when it takes to these decisions, just sit down, take, even if it needs to take months, look at your financial situation, then look at your family situation, and then look if you want to stay in Pakistan and practice, or you want to go outside Pakistan and practice, then which country you want to go, where is more suitable for you. So these are the decisions you need to make, and then based on that, start studying books from that country. Do not study book from the other country and giving exam to something else. It should be lined up. So what my advice is.
Okay, sir. Thank you so much. And any remarks about OHC, any improvement
Yeah,
you
you guys
want to
doing
share?
excellent work. Excellent. Just keep doing it. Okay. Uh, and I hope that more students would benefit from this forum.
Inshallah.
That's so kind of you,
All
sir.
right
Thank you
then.
so much, sir.
You guys take
Yes.
care.
Thank you so much for your time. Stay
Thank you,
blessed.
sir.
Thank you. Allah
Have a
Hafiz.
great day. Allah Hafiz.
Allah Hafiz.
Allah Hafiz. Allah Hafiz.
Allah Hafiz.